Bismillah ar-Rahman ar-Rahim. Syndrome of inappropriate secretion of antidiuretic hormone. SIADH. Definition and etiology. Excessive retention of water relative to electrolytes due to inappropriate production of antidiuretic hormone. Hence, there is hyponatremia below the sodium in the blood is below 135 millimole per liter, hypoosmolality, a urine osmolality is more than 100 milliosmol per kg, a urine sodium concentration usually above 40 millimole per liter, normal acid base and potassium, and usually a low plasma urea concentration. Diuretic-induced hyponatremia will be accompanied by evidence of dehydration, such as raised urea. The causes of syndrome of inappropriate secretion of antidiuretic hormone include drugs such as carbamazepine, fluoxetine, and high dose of cyclophosphamide. Post-major surgery may cause syndrome of inappropriate secretion of antidiuretic hormone. Pneumonia also it may be a reason. HIV infection can cause that syndrome. CNS disorders such as stroke, infection, psychosis also may be reason for that syndrome. Small cell lung cancer, either ectopic antidiuretic hormone production or stimulation of normal antidiuretic hormone production is a major cause of that syndrome. The clinical features: lethargy and confusion, often when sodium levels fall below 130 millimole per liter, and nearly always when below 120 millimole per liter. The investigations of syndrome of inappropriate secretion of antidiuretic hormone include doing serum sodium and low sodium in the presence of a low urea and inappropriate clinical setting may be adequate to make a diagnosis. If the sodium depletion and water overload are possible alternative cause of hyponatremia, they should be accompanied by a urine osmolality below 100 milliosmol per kg or a specific gravity below 1003 or urine sodium below 40 millimole per liter. Therefore, values increasingly above this are suggestive of syndrome of inappropriate secretion of antidiuretic hormone unless the patient is on loop diuretics, when of the course the urinary sodium concentration will be higher. The management of inappropriate ADH secretion: fluid restriction 0.5 to 1 liter per day will help but is often unpleasant for the patient. Salt tablets and extra dietary salt may be required, may resolve over a few weeks following chemotherapy. Hypertonic saline is rarely indicated and can provoke brainstem damage, demyelination through rapid changes in osmolality. Drugs not routinely used but may be useful include dimi- dimeclocycline in dose of 450 mg BD, tetracycline derivative, which blocks antidiuretic hormone action at the distal renal tubules and can be used for long term, or tolvaptan, tolvaptan in dose of 15 mg OD, V2 ADH receptor antagonist. We should monitor the sodium concentration every 6 hours during the first 2 days of treatment and monitoring of liver function tests. In addition to renal function tests.